Good afternoon. Our speaker today is Dr. Mary Stoykov from Northwestern. Um, Thank you very much for coming and presenting for our journal club.
Thank you very much, and thank you to you, Asol, and to Susan Atwood for inviting me, and to Dr. Savitz. I really appreciate talking to you, and it's an honor. Okay. So the title of my talk is The Behavioral and Neurophysiological Effects of Bilateral Motor Priming in Task-Specific Training and Chronic Stroke. And so this was I did the previous studies for that went into this, and I wrote the grant for this study and started the grant at 2020. We had a PhD student started who actually had also helped me in the first study, in the previous study, and she got her PhD from this project, Erin King. And these are the disclosures about the funding for the grant. So just background. I'm going to briefly review the background of the study and the purpose, and then some evidence-based interventions for moderate to severe chronic hemiparesis. We're going to present the results of the trial, and then just also one of the things we found, discuss the use of the motor evoked potential as a predictive biomarker. And then hopefully we'll have time for questions and discussions. So this research matters because there are very few studies that examine moderate to severe chronic hemiparesis, and there's a very limited understanding of the underlying neurophysiological mechanisms. Most studies use more mildly impaired patients, as well as patients who have motor evoked potentials. Excuse me. So previous studies of post-stroke hemiparesis, these are the large clinical trials, and with the purple stars are the ones that had significant results. As you can see, the EXCITE trial, the constraint-induced movement therapy, as well as a GRASP study, which was a self-administered exercise program. Both of these studies were for mildly impaired patients. They were much less impaired than our subjects. And then there's recently the VNS, vagus nerve stimulation plus task-specific training. They also had slightly less impaired subjects than we did, but more impaired than the EXCITE trial. So the mechanisms of post-stroke recovery are not well understood. Most trials do not investigate, but I mean big clinical trials, not small ones, but larger ones, do not investigate the influence of training on changes of the brain. This is because it's very difficult to do in a clinical trial. It takes a lot of time, and even fewer studies report the measures from both hemispheres. The trials which do investigate brain changes post-stroke in upper extremity hemiparesis have more mildly impaired participants, smaller sample sizes, and more varied design and outcomes. So our study was bilateral upper limb motor priming, and this is a neuromodulatory technique which supposedly helps the brain to rebalance corticomotor excitability. And this is what it is. This is called the primer, and you do that for 15 minutes. We do it with a metronome and try to do 1 hertz, 1 cycle per second. And you do that for 15 minutes prior to some type of intervention, like task-specific training. In our feasibility study, we found that we had like a 10-point difference here between the pre and the post in the priming group. The other group had a educational, like 15 minutes of stroke education prior to the same task-specific training protocol. And they did improve, but to a lesser extent. And as you can see, the two groups at follow-up, this group improved, the priming group kept improving and continued to improve at follow-up. They had like a 10-point difference. The other group also continued to improve, but there was a greater difference in the, there was a greater magnitude of difference in the control group versus the bilateral priming group. So the first study of this was done by Stinier in 2008, and they found, this was in chronic patients, they found that the ipsilesional, which is the map, the brain of with the lesion, the volume of the extensor carpi radialis had increased, which is a measure of excitability, and also the interhemispheric inhibition from the ipsilesional onto the contralesional hemisphere had increased. And in our study, our small study of 16, we found that the priming group increased the ipsilateral silent period, which we'll go over later at follow-up versus, at post versus the control group, which did not have a change. So combine these results suggested that maybe priming would facilitate a rebalancing of cortical motor excitability, and priming may contribute to a more normalized inhibition in this population. So I just want to take you through the protocol for the BUMP trial. We had 76 patients with chronic stroke, and they were randomized to receive either bilateral motor priming or the control priming. The control priming was like a sensory stim, transcutaneous stim of the hand. We turned it up to where they felt it, and then we turned it down to 1 milliamp, and they had it for 15 minutes. So it's like a sham stimulation. And they received a total of 30 hours of priming plus therapy over 6 weeks. Task-specific training was delivered by an occupational therapist. And we also gave them a home program activity of 3 to 5 exercises targeting range of motion, isometric activation, etc. And they were supposed to do that for 10 to 15 minutes per day. For those of you who want to look at the whole protocol, the task-specific training protocol, it is in the appendix of the paper that was sent out. So there's a appendix. It should be, when you go to PubMed, it should be right underneath the paper, and you can go through the appendix, and I think it's the 3rd or 4th appendix, there's a whole protocol with the different grasp activities, the different release activities, the different reach activities. We try to minimize degrees of freedom in the beginning for the participants because they can't do both grasp and reach together. So we also do the COPM goals. We took the COPM in the beginning, and we have them identify 3 to 5 goals for them that they need to be able to do or want to be able to do. And we do that in the second part of the training. So this is just a pre and post of one of the COPM goals. He wanted to open and close a door. So as you can see, he has difficulty maintaining his grip, meaning difficulty positioning the grip, and then he uses his body to try to turn the handle. Okay, and then this is at post. And as you can see, although he's still impaired, we don't mean to fix these patients. They're lower Fugelmeyer scores. He was able to maintain his grip on the handle. He had a better grasp, and just his movement was more, had a better quality. Oops, sorry. I wanted to. Sorry, I have to get out of this. Next one. Okay, so we screened 1,857 patients by phone, and of those, about 1,500 did not meet eligibility criteria on the phone. So then we bring the other ones in for a lab screening. Of those who came in for the lab screening, which is about over 300, 156 did not meet the criteria. So we ended up enrolling 81, 76 were randomized, and then 38 were assigned to the bump and 38 to the control group. And we ended up at the end to have 37 in the bump group in the intention to treat analysis and 36 in the control. For the analysis, we used confirmatory analysis of the primary endpoint, which was the Fugl-Meyer, and it was looking at the follow-up minus pre-change, because that was what we expected the largest change to be. We also did a follow-up of the number of participants with a clinically meaningful response. And the clinically meaningful response that we picked was greater or equal to 6 points on the Fugl-Meyer from baseline to follow-up. So what we found that there was no significant difference between treatment arms. I was disappointed, but this is how it came out. We replicated our first pre to post, where we had about 6 points increase in the Fugl-Meyer, but then at follow-up, the bilateral priming group did not continue to change. So both groups had a change of about close to 6 points, a mean change of 5.68 for the bump group and 5.8 for the control. 50% of the subjects in the 50% of the subjects in the control priming group had a clinically significant difference. We categorized them as responders, which was 6 or greater points on the Fugl-Meyer, whereas for the bilateral motor priming, there were 46%, but there was no significant difference. And then for our secondary outcome, we use the Shadok Arm and Hand Activity Index, which is a bilateral measure using functional tasks such as opening a jar, wringing out a washcloth, putting toothpaste on a toothbrush. And for our attention to treat analysis, we had like 7 dropouts from the bump group. We had a 5.62 change from pre to follow-up, and then for our control priming, we had a 3.2 change score. This is the complete case analysis results, where only the individuals who had all the time points were analyzed. So the people that were dropouts were not analyzed in this complete case analysis. And it was a slightly different. We had a larger change for the bilateral priming group, but this is the more statistically sound. The intention to treat is more statistically sound. It's more like real life results. So our interpretation was that there's obviously no benefit of bump was observed here. That was in contrast with prior findings. We were not able to replicate the results of the original study. This might be because we had 16 subjects in the feasibility study, and we had a few participants who had large responses in the bump group, and that may have skewed the results. There's also always going to be an attenuated treatment effect with a larger sample size. But in this study, both groups improved by 5 to 6 points on the Fugl-Meyer, demonstrating that 22.5 hours of task-specific training can produce meaningful change in chronic to moderate to severe hemiparesis. So to interpret this, we have to consider that we did not use an invasive technique for this to get this change. We did get the same similar change to the VNS study at the same time point, at the 6 or 8 week follow-up. They had close to a 6-point change as well. So you should consider the risk to benefit ratio for patients before implementing more invasive strategies. And this is one of the largest upper limb trials in a severe and chronic population, and the first to show this level of improvement with a clinically feasible intervention. Remember that both types of priming are, can easily be used in the clinic. So the TMS outcome measures for the interhemispheric inhibition, we used the ipsilateral silent period, which is collected from one hemisphere. It's not the dual hemisphere. And this is because it's easier to get this measure in more impaired patients. So what happens during the ipsilateral silent period is you contract the less affected hand for 50% of MVC. And in the meantime, you do on the ipsilegional hemisphere, you send a strong stimulation of 150% resting motor threshold to the ipsilegional hemisphere. And what happens is that onto the contralesional hemisphere, what happens is you get an interruption of the EMG. And you can see that right here. Here's the stimulus, and then here's the background EMG. And then at the onset, which is you count as one standard deviation below the pre-stimulus mean EMG, you get a decrease in that EMG signal. And in this case, it was 72% inhibition. For the corticomotor excitability, we looked at MEP status on the ipsilegional, on the lesion side of the hemisphere. And so we found that some individuals had, and this was during active movement, it wasn't resting MEP. We had them activate as much as they could on both sides and to see if we could get a MEP from the ipsilegional side. And then we also did a resting motor threshold value for both hemispheres. We did peak-to-peak amplitude, and we did the MEP latency, which is the stimulus to the MEP. The peak-to-peak for the resting motor threshold, we measured it at 100% resting motor threshold after we did a recruitment, and then for the MEP slope of the recruitment curve, we looked at 120% resting motor threshold. So this is 80% right here. This is 100% resting motor threshold, 120 and 160. So our initial hypothesis was that we would have an increase in cortical motor excitability in the ipsilegional hemisphere. And this would be measured by a decrease in the resting motor threshold, a decrease in the latency of the MEP, and that these changes would be significantly more greater in the bump group rather than the control group. And then for interhemispheric inhibition from ipsilegional onto the contralesional hemisphere, we hypothesized there would be an increase in the depth and duration of the ipsilateral silent period from the ipsi onto the contralesional hemisphere. What we found, though, was that bump had no effect on either measure at post or follow-up in either hemisphere. And this was the same in the results were both the same for the bump and control group. Here you can see the resting motor threshold. This is a bump group. They had a higher resting motor threshold at baseline, post, and follow-up. And then, excuse me. Then this is the MEP amplitude, and this is the MEP latency. And this is at pre and post. And see, as you can see, there were no significant differences. So for the measures of interhemispheric inhibition, for the depth of the inhibition, we had no difference between the ISP depth, which is the depth of the silent period, the duration in milliseconds, or the persistence. The persistence was just the number of silent periods out of 16, or the percentage of actual stimulations that we gave that had a silent period that was 50% or more below the background EMG. So our summary and interpretation is that there's no between group differences in corticomotor excitability or in interhemispheric inhibition were detected following the bump plus TST versus the control group, and no differences in time over any measures of either hemisphere in response to the task-specific training or the bilateral priming. There was a high number of missing data points from the ipsilegional hemisphere, and that was because we had a more severe sample size. So They may have had a MEP presence in their ipsilegional hemisphere, but they may not have had a resting MEP, which is a MEP when the arm is at rest. We're still confident in our findings because of the sensitivity analysis. We think that the TMS-derived outcomes may not reflect all the relevant physiological changes in an intervention, so that perhaps the TMS measures are just don't have enough resolution. And the results also suggest that behavioral gains can occur without corresponding changes in TMS measures. So I wanted to talk about MEP status as a predictive marker. So in this consensus paper that was written for the International Journal of Stroke, there was a consensus that said that MEP status is a predictive marker of stroke recovery and should be used in clinical trials for stratification or for elimination of certain participants. However, we found we divided the participants in both groups by MEP positive and MEP negative, and then we looked at the change in the Fuglemeyer, and we found almost exactly the same. We did have a higher baseline Fuglemeyer in the MEP positive participants, about 5 points average higher than the MEP negative. However, their change from pre to post was no different. The rate of the magnitude of their change was no different between MEP positive and MEP negative. So in summary, the MEP status at baseline did not predict who would respond to training. And this was consistent with a previous study from Powell and her colleagues at Dr. Sawaki's lab. And both MEP positive and MEP negative participants showed Fuglemeyer improvements, supporting more inclusive treatment approaches. And these findings question the value of stratifying participants by MEP status in chronic stroke trials. And we should not use MEP presence alone to exclude or to stratify individuals from study or intervention. So just the conclusions, that 22.5 hours of task-specific training. Remember, that was the number of hours of training besides the priming. The priming had its own number, and it was a total of 22.5 hours over 5 to 6 weeks. And it produced meaningful gains in the upper limb. It did bump the bump group. The bump priming did not enhance behavioral outcomes, nor did it produce any changes in corticomotor excitability or interhemispheric inhibition. And most importantly, MEP status did not predict response to treatment. So this extends prior studies on bilateral upper extremity motor priming, and it's using a larger, well-characterized sample size. And it also shows that functional gains can occur without changes in TMS measures. This study questions the utility of MEP status for stratification in chronic stroke and supports inclusive informed approaches for upper extremity rehabilitation. So I'm hoping there's some questions. Any questions? Are there any questions?
Mary Ellen, this is Jinsuk. It's great to see you again. How are you?
Good, very good.
Very good, very good. Thank you so much for presenting very interesting the work. I'm just curious, what is the kind of the neurophysiological kind of basis of the effects of the priming? I mean, what was your scientific rationale to test the effects of the priming in your study?
So we believe because of prior studies, our studies and the Stenier studies, that there was a decrease in interhemispheric inhibition from the ipsilegional onto the contralesional hemisphere. So that made the contralateral hemisphere had more say in what was going on, sort of the interhemispheric imbalance theory. Now, over the years, since I started that work, that has come out of favor, that theory that that there's an imbalance in interhemispheric excitability. It may be for some stroke patients that there's an imbalance, but it's clearly shown in this study and in others that it is not, that there is not necessarily that the whole thing with the contralesional hemisphere inhibiting the ipsilesional is not true for all stroke populations. So that was one thing. We thought that because we're upregulating both hemispheres with the bilateral priming, that the inhibition would normalize, meaning that the ipsilesional would be greater. The ipsilesional inhibition onto the contralesional hemisphere would increase. And so there would be more of a normalization of inhibition. Does that make sense?
Yeah, thank you.
Mm-hmm. With the priming, there was only, I didn't see that. Can you read that in the chat
Oh, yeah, it says
Mr.
there was only facilitated range of movement with elbow, wrist, and hand. Joint compression or loading, unloading with the range of movement was not included in the mechanism. Is that right?
No, so the whole point of it was more for a rebalancing of the hemispheres. It wasn't a joint loading hypothesis. And it was really both wrists, bilateral wrists. The elbows were stable. So it was just the two wrists that were moving during the priming. During the task-specific training, we did more joint movement. We did, reaching, trying to work a lot on the elbow and the shoulder movement, the transport phase of reach, extending the elbow while the shoulder was flexing. So we did other range of motion activities during the task-specific training. Yes?
I think Naveen's got a question.
Okay.
Yes. This is very interesting study indeed, and thank you for being very honest to show these results. Do you think that when we are priming both hemispheres, then we are emphasizing still the imbalance? Maybe if you primed only the lesioned hemisphere to correct this imbalance, would it be better?
So that's a really great question. And I looked at we're looking at the results for the TMS for the paper, and both hemispheres, there's not that much difference in baseline, even in the depth of the silent period. So it may be that, this is that maybe they didn't have that much of a deficit. Maybe that the whole thing about the the decrease in the ipsilesional to contralesional hemisphere inhibition doesn't apply to this, all stroke patients.
Yes.
But anyway, that didn't happen because I can see why you would think that, but that didn't happen because the results, we also took the other hemisphere from the contralesional onto the ipsilesional. There was not that much difference in the depth of the silent period.
Okay.
I have a couple of questions.
Okay.
I wanted to first say thank you for your presentation and for doing work in this area. I think it's very important for us to be looking further into this, especially as occupational therapists. The first thing I wanted to confirm, the primer machine, it was purely passive, is that correct?
No, it does not have a motor. It has an actuator underneath which couples the two hands, but you have to do it with the other hand has to drive the weaker hand. And so
okay.
even the weaker hand, you can try to get activity from that hand as well. It's more of an active assist, I would say, than just purely passive. But that's a great question.
Okay, thank you for that. And the second question, I was curious if you could elaborate more on the sham stimulation in the control group.
Yeah.
I've seen prior work in spinal cord injuries where they're using subthreshold neuromuscular electrical stimulation, specifically over the median nerve in the spinal cord injury population, to try to, and they're seeing improvements in sensory motor function. So I was wondering if the parameters that you all were using for your sham, if that was similar, and potentially if that could have had an effect on that population.
It wasn't similar. We went all the way down to 1 milliamp, like the lowest setting you could have, without turning off the machine. So it was not, I think with sub-threshold, what they do is they bring it up until they feel the sensory threshold correct, and then bring it right below that. Or are you talking about sub-motor threshold, which is they bring it up until there's a twitch and then go below that? That's usually what they use. Go ahead.
Yes, I was going to say it's, I think it's subsensory, but it's also the parameters with the pulse width and the pulse rate are both very low as well.
Right. I think so. I'm learning about this for the spinal cord. I'm learning that it's below the motor threshold, or whatever they can tolerate. I think it might depend on the protocol. However, nevertheless, though, we went all the way down to the 1 milliamp. We were usually you're at maybe at 12 or whatever if it's sensory, or you higher if you're looking at the motor twitch, and then you go right below. So this was really, really low.
Okay, thank you.
You're welcome. Someone else had a question that was in the chat. Someone else wrote a question about the neurophys measures.
I can read that for you. It was from Shashwati Geed at UTEP. She asked, which neurophys measures do you think might make optimal outcomes for mapping motor recovery in trials, given these excitability outcomes?
Well, these outcomes don't give a lot of confidence for the TMS measures that we did use. And the TMS measures we did use are the ones that are usually used. Like, for instance, motor threshold, motor amplitude, the slope of the recruitment curve. Maybe because this population was lower functioning, they just didn't have enough. There wasn't enough resolution in the measurements. I'm not sure what else you could use in this population. I haven't seen a large study this large where they use TMS measures where there was significant difference in the measures. I mean, that's one of the things about the unusual things about this study is that we actually did the TMS measures. And the reason that we did them, because it was very difficult to collect that for 76 people. And some people don't tolerate it well. And is that because we said that there was interhemispheric inhibition that may be modulating that, we wanted to show it, we wanted to show neurophys measures. We couldn't just say it was because of if we had an effect, it was because of the behavioral measures. So we did have an effect, but it wasn't because of the measures, the neurophys measures that we thought. I mean, both groups improved, and 50% of both groups had, were responders. So it's like, we don't know what the mechanism is. If there's a neural mechanism, we don't know what it is. And if there were other trials, perhaps because if there were more mild impairment, you could use these measures like MEP, resting motor threshold, and MEP amplitude, and peak to peak, and such, and the slope of the recruitment curve. But for this study, there wasn't a difference. So I'm not confident that any intervention with this low level patients could show change. Remember that when you go from a smaller study, which is showing changes, to a larger population, there's always an attenuation of the effect. So if you have these small effects in these neurophys measures, they're not going to stand in, when you get a larger sample size. I hope that answers your question. Okay, thank you. Does anyone have any questions about the ipsilateral silent period?
Guess that'd be a big fat no.
I'm sorry?
I don't have a specific question about it, but I would love to hear your thoughts on it.
On what? I'm sorry? On the ipsilateral silent period?
Yeah.
Well, we just had an investigator here who showed her work. She uses the opposite of what we use. Dr. Powell uses the ipsilateral silent period from the less affected onto the affected. And she has mixed results also, which she puts into a model that the contralesional hemisphere does not work the same for all levels of stroke impairment. So I'm not sure. I think that we're trying. I think initially when that the excitability, that the excitability hypothesis, which was that the contralesional hemisphere is inhibiting the ipsilesional, and the contralesional hemisphere is more excitable than the ipsilesional. I think it was just a great way to think about, well, this is great. I mean, we can teach this and we can explain things like this, but it just didn't happen that way. I mean, from the work of Budafish and others, that hypothesis doesn't really hold. That it's because of the imbalance of the contralesional hemisphere exerting too much inhibition in the ipsilesional. What we actually found, and I didn't present these results, was that in individuals who were MEF negative, the contralesional hemisphere had decreased excitability, meaning they had a higher resting motor threshold. So that if you did not have a MEP from the affected hemisphere, the other side of the hemisphere had less excitability as well. So both hemispheres were downregulated. So there wasn't necessarily an imbalance of inhibition. We had both hemispheres that, needed more excitability. And that's for the MEP negative individuals. So what we're finding is not what, does not follow that theory of, and I remember talking about this ground a long time ago when I was, when we were doing the feasibility study, and I remember I talked to Dr. Wittenberg about it, and he was like, this was, a couple years ago, and he said, well, that theory doesn't hold anymore. That's passé. And I was like, oh, some people are still talking about it. This study doesn't, this study does not support that theory. There might be some studies that do, but I think that it's just a lot more complex. It may depend on where the lesion is, whether it's a cortical lesion or whether it's a subcortical lesion. I think it was a Thickbroom who did a study on that, it depended on where the lesion was. So the contralesional hemisphere has been there's been a lot of discussion about the contralesional hemisphere, and the literature, there's literature's really all over the place. So we're not quite sure how this excitability between the hemispheres, what it means. And it may mean something different in the subacute phase than the chronic phase. I actually looked at a lot of papers with transcolossal inhibition and the silent period, the ipsilateral silent period. It has a lot to do, in some papers, they say it has a lot to do with, the motor function improving. And in the aging population, the ipsilateral silent period, the decreases. There's decreased inhibition between the hemispheres. So it's it's a really interesting topic. I just don't think that our hypothesis held. That might have been more than you wanted to know, but.
That was super helpful. I've been following your research for decades, and I always appreciate how much you do such well-designed studies, but then also make it clinically applicable to practicing occupational therapists. You make that connection through this really high scientifically inquiry, but then also make it practical for therapists. So thank you for that.
Thank you. And you can, like I said, you can see the appendix if you wanted to look at the appendix and get any treatment ideas on, how to do grasp and release for these more severe patients. It's not that easy. It's,
Yeah, I already downloaded it. Thanks.
Oh, great. All right.
Thank you for the question. And since you did the COPM with the patients, did you follow up with that as an outcome measure as well?
We didn't use it as an outcome measure. We used it as a guide to treatment. We did the pre and post. We didn't do follow-up COPM. In our prior study, we haven't actually looked at the COPM results, and we could do that. In our prior study, we didn't expect a change, a difference between groups. So both groups improved in the COPM. Both groups, were more satisfied with their occupational performance. And actually, I would expect that in almost any upper limb study, because, it's their perception. And I even talked to someone from Canada about this who started the COPM and said, well, there's difference in the motor measures, but there's no difference in the COPM. And she was like, well, it could also be because the patients like the therapist. I mean, there's a lot of things in the COPM because it's patient centered that you can't transfer it to how great they are with motor efficiency and how great they are, how well they're doing, because sometimes they perceive that they just perceive it differently. But I'm sure there's a pre-post difference. There's a pre-post improvement. We just haven't looked at them yet. And I would be very surprised if there was a between group difference. I would be shocked. So. Does anybody have any questions about the COPM? And what we do in the first session of the therapy is work on the grasp and release components that they will need for their COPM goals. So if they need to be able to, hold up or hold their pants, we try to get grasp activities, at different levels, maybe below the waist, where they can maintain the grasp, while they're trying to, manipulate the clothing. So we try to use the first activity to inform the second, the COPM goals optimally. Yeah. Does anybody have any ideas how they would do the study, how they might have done it differently? Jin-Suk, I thought you might have a suggestion.
Sorry, Mary Ellen, what was the question?
Does anybody have any ideas how they would have done the study differently?
Actually, I was curious. So you paired this priming with the task-specific training, correct?
Yes.
So what was the task-specific training in this case?
So the task-specific training is 2 parts. The first part, they work on different activities to, to help them with grasp. So maybe like picking up an object. So because they're more severe, it's hard for them to pick up an object. So maybe I'll have the therapist, or they'll start on the table with their arm resting on the table, and then the therapist will stabilize the object so they can learn how to grasp. And then as you go along, hopefully they can maybe grasp without it being stabilized, or maybe not. Maybe they'll always have to stabilize to be able to grasp. We also work on things for release, like releasing onto the floor first because of gravity's assisting. We use weighted objects because that will relax the long finger flexors initially. So there's just different ways of breaking up the grasp and reach by manipulating the degrees of freedom. For instance, like, using a table and resting their wrist on the table, it's going to be easier for them to reach to a target or to an object, right? Instead of doing it free in space. So those kinds of things were done in the first session, or the first 45 minutes. The second 45 minutes was the Canadian Occupational Performance Measure task. So if one of their valued occupations was, tying their shoes, we would work on tying their shoes, different ways that they could either modify the task or just, like different postural sets, maybe, putting their foot up on their leg, crossing their leg so they could reach it easier, or whatever it was, putting their foot on a stool. But trying to improve the task without using too much adaptive equipment. So it wasn't one-handed, so that it wouldn't be a one-handed task, it would be a two-handed task. The only adaptive equipment we allowed were sometimes the build-up grip for like silverware. Even that I like to, though, progress, because the build-up grip, if you're just using the build-up grip, you're just holding it with a grasp, with that grasp, and you're not developing the in-hand manipulation. So just
talking.
I'm sorry. So anyway, that was how we did the task-specific training. We start out with like more basic reach and grasp, and then the second session we did the activities that they identified on the COPM as if they wanted to do or needed to do.
I see. Actually, for me, the idea of the priming effect, that sounds very interesting to me, but I'm just curious about like what exactly the prime works, meaning like sounds like the priming is mostly done on the wrist joint, and the task-specific training sounds like it involve a lot of more distal joints, like on hand and fingers.
Yeah.
So then is the priming effect necessarily kind of generalized into more distal components?
That's
that's
a good question. That's a great question, Jin-Suk. We think the wrist is, that's like a distal joint, so it has a larger space in the motor cortex. But it's also, you can do that 1 degree of freedom range of motion with the wrist, with this instrument. For us, it didn't work, but I thought it was a great idea when I first started doing it. I thought it was fascinating, and it worked as I said, it worked in the pilot study, and it's worked, I believe, in the Stinier did a study in the subacute phase where they had they reached their their improvement was faster. Eventually, everybody caught up. Again, over in New Zealand, the patients are less severe than our patients here, at least, and I'm sure at your hospital and here, at the Shirley Ryan Ability Lab, the patients are, we can just look at their Fugl-Meyer scores in the study, and they're very much more mild than our patients are. But they did have a faster improvement, those that did the priming. As far as priming, the most results I have seen are the sensory stim, or the nerves, peripheral nerve stimulation, just right below motor threshold. And that's what, there's studies I've seen that have had positive results for that. And so I haven't seen really great studies for TTCS, or RTMS, not large studies anyway. So I'm not saying that they couldn't work, but it looks to me like that not all the priming things that I thought worked, would work great. It doesn't necessarily mean that they do. And but it is supposed to be a generalized effect, meaning it's not supposed to just be for the wrist. It should be for the, like the whole hand and arm, if that makes sense.
Yeah. So basically my question is more about like the nature or the characteristics of the appropriate priming task. So question number one, whether the priming needs to be done on the same kind of segments of the joints that would be actually used for the following task-specific training, or what nature of the priming actually really prime the brain activity? I mean, with the symmetry?
We think it's because of the symmetry. So that theoretically, if it worked, we believe it could also possibly work with elbow flexion extension, because when you are doing the same symmetrical movement, both hemispheres are, activating, right? And whether with this, they're not activating at the same intensity. So they've been shown that both symmetrical movements have been studied, and both hemispheres are activating during bilateral symmetrical movement. So that's what we thought would, I started looking at bilateral symmetrical movement versus unilateral movement for training purposes only when I first started. And I saw small differences in the bilateral training, but both groups improved. And then I went on to the bilateral priming. And it seemed to work. It worked really well with the feasibility study, but when we went to a larger sample size, the effect attenuated. So I can't say that it works. I'm not going to write I don't think I'm going to write another grant for the bilateral priming in the stroke population. But as far as, so you wanted to know, as far as any priming technique, it's supposed to generalize and not just be like for, one joint. Now, the wrist joint is one of the most important joints in hemiparesis, because you want one, if you want one joint that really is going to get better, it's wrist extension, right? Because you need that, to be able to pick up objects with more efficiency, to position the hand. However, it's not supposed to go directly to the wrist. It's supposed to like be a global priming. And I believe that's with all the priming techniques. It's supposed to be, it's just not joint specific. I've never seen any literature about it, but I don't think it's joint specific. But yeah, so I've gotten a little bit less, I really like the sensory stimulation that people are doing, but both, even the transcutaneous spinal cord stimulation, but also the peripheral nerve stimulation. I mean, I've seen that results in acute when I've worked with patients on it. I've seen it like instantaneously. So I like I think that one has more potential as a priming mechanism, and it is already used in the clinic, but I'm not sure about some of these other priming mechanisms that we have. Mirror therapy probably works on some people.
I see. Thank you.
Mm-hmm.
Going back to your question about what I would do if I would repeat the study, maybe I will, instead of TMS, I can use EEG connectivity, because it can give me an idea about the nearby areas around the infarcted hemisphere.
Mhm.
Maybe they can be recruited, maybe increased the connections
Yeah,
are the cause of the improvement that we could not pick up with the TMS.
yes. That's a great suggestion. I think that's a
Mm.
great suggestion. Hopefully people are using that technique more now in their clinical trials.
I'm using it with my team for cases of aphasia.
Oh, great. That's
Yes.
great.
Mhm.
Yeah.
Still, we have preliminary results, but not the full results are available.
So you're using it to look at, you're using it to look at changes in the brain after
Yes,
treatment.
comparing at baseline cases of aphasia with healthy controls, and then we perform DCS, TDCS for patients of aphasia, and we measure before and after, and we actually find major differences between before and after in the EEG connectivity.
No, that's awesome.
Mhm.
So maybe that will be I know a lot more people, investigators are using that technique now, so it maybe have more resolution than, TMS
Yes,
TMS
maybe.
techniques. Well, I want to thank you everyone for their attention and for their great questions. It's just very interesting for me to hear your questions and your comments about the study.
Thank you.
And you can reach me if you have any more questions at mstoykov@sralab.org. Thank you.
Great talk, Mary Ellen. Thank you.
Thank you, Inchas.